Alright guys, it's Jake again. We are ready to roll with the next session for our Gross 2 lecture pass. Last time we left off talking about the thyroid gland. Again, it's found at C5 to T1. It regulates your metabolic rate with thyroxine. It regulates your calcium homeostasis with calcitonin. And it has a left lobe, a right lobe, and an isthmus. Moving along now, one of the numbers you're going to want to know for this first exam is approximately 50% of thyroids have that extra lobe. That extra lobe is lobe is your pyramidal lobe. It extends upward from the isthmus, and it's just more of that glandular tissue. Another common variation found associated with the thyroid gland is the levator glandulae thyroidae muscle. This is one where we haven't seen a test question over this one yet, but I like to point it out because I feel like if he was going to write a new one, he might pull this guy out of nowhere just because it's such a long one. It could be a potential fill-in, something like that. But again, he likes things that have variations. Dr. Duray does. In this muscle, your levator glandulae thyroidae is one of those variations. And it'll connect your isthmus to your hyoid bone. So, again, we haven't seen it too much in the past, or really at all, but something to keep on your radar as you're studying. And now we're on to the blood supply of the thyroid gland. Your thyroid is a super vascular tissue. It's going to be supplied by your superior and inferior thyroid arteries. I think it's worth noting that the superior is an extension of your external carotid, and then your inferior is going to be that thyrocervical trunk. Essentially, your superior thyroid artery is coming from above, and your inferior is coming from below, or inferior. So the names tell you exactly where they're coming from and what they are. Every once in a while we'll see a test question about where they're actually coming from as far as other arteries. So anatomical variation, again, we see variation. Every time you see variation, think potential test question. In this case, we're talking about the thyroid ima artery. It's present in about 10% of the population, and it can be damaged via emergency tracheotomy. This one is typically a quiz question. I'm not sure if he's having you guys do quiz questions or how your lecture's going, but if it's not a quiz question, it can be a possible test question. And the thing there is just knowing that 1/10 of our population has it, and it can be injured during a tracheotomy. You have 6 total veins that are extending out from your thyroid gland, superior, middle, inferior. Pretty straightforward. The thing that I'll point out here is your inferior thyroid vein is kind of your odd man out because it is going to your brachiocephalic, while your superior and middle are going to the internal. Now we have goiter, so something related to our thyroid gland here. It's an abnormal enlargement of your thyroid gland. We have 2 types. This is a very common test question we've seen in the past. Just be able to differentiate between an endemic goiter and exophthalmic goiter. So your endemic is linked to an iodine deficiency. So because your iodine is needed to make thyroxine, the gland will enlarge. It enlarges to hopefully increase that output of iodine, even though it's already kind of being inactive because of its deficiency. Patients tend to gain weight, feel tired, and maybe even feel cold. This one, so we're talking endemic. We are associating that with hypothyroidism. Endemic hypothyroidism. Now when we talk exophthalmic, this one is due to an immune disease. When we say immune, we're talking about Graves' disease to be specific. So this results in overactivity of your thyroid gland. So you can get some weight loss, you can feel hot, you can have a heart arrhythmia, just your heartbeat's kind of going out of whack, and this is where we'll see those bulging eyes. Now for exophthalmic goiters, we are thinking of hyperthyroidism. Essentially, they're just opposites of each other. Make sure you study this. There's usually a test question about it. Next, we are going to hit on our parathyroid glands. So these guys are essential to life. The reason they're essential is because they play a pretty decent role in your calcium homeostasis. Typically, you'll have 4 parathyroid glands, but that number can vary from 2 to 6. It has inferior thyroid artery and superior thyroid artery as its blood supply, which is the exact same as your thyroid. Down here, we get to factors contributing to difficulty in thyroid surgery. So, again, like I said earlier, it's incredibly vascular. So if you are doing some kind of thyroid surgery for whatever reason, potentially trying to reduce the size of a cancerous lesion or something like that, surgeons are going to be very careful because, again, vascular, it's surrounded by many blood vessels. And if you were to nick one of those, you could have some pretty severe blood loss. Now, and again, we have our presence of parathyroid glands. So if you go in working on the thyroid, you accidentally damage some of these glands, it can really mess with your calcium homeostasis, which is obviously not great. And then we also have that recurrent laryngeal nerve, very close to the thyroid cartilage, or excuse me, thyroid gland. So that recurrent laryngeal nerve is a branch off the vagus. It travels up the neck to supply motor innervation to all but one of your laryngeal muscles. So essentially, if you were having surgery on your thyroid and this recurrent laryngeal nerve was damaged, you could have some kind of paralysis of your larynx, which would just be super bad news. But again, usually some kind of test question. Now we're on to the trachea. Got to know the level. Trachea, C6. It's also known as your windpipe. It's going to be what splits into your left and right bronchi, which extend into your lungs. It has a series of incomplete cartilaginous rings. It's important to note that these rings open posteriorly. And then because they open posteriorly, there is a gap there, which you can kind of see in this picture over here. That gap allows for the expansion of the esophagus, and it is spanned by the trachealis muscle. Trachealis muscle has been a fill in the blank in the past. That's the important stuff about the trachea. Now we're going to move on to the esophagus. It's going to begin at the same level as the trachea, so C6. And it is posterior. This is one where, for whatever reason, people will assume that your esophagus lays anterior to the trachea, but it is posterior. So every once in a while, you'll see this come up on your exam. So just make sure you hammer home. The esophagus is posterior to the trachea. Now we're talking about our carotid arteries. The difference between the internal and external almost always test questions, mostly about what they supply. So the internal carotid artery is going to enter through the carotid canal, and it is going to supply blood to your brain. Blood is getting to your brain through the internal carotid artery. With your external carotid artery, this guy is the source of blood to your neck, face, and scalp. So your kind of like external structures. Internal, going internal to the skull. Your brain is internal to your skull, so that's why the internal carotid artery is supplying blood there. And then external, we're talking about external structures, neck, face, and scalp. We have another rather common test question down here about the 8 branches of the external carotid artery. Usually, if he asks a question about it, it's more about number 7 and number 8. Superficial temporal artery and your maxillary artery. These are the terminal branches of the external carotid. Terminal branches of external carotid. Branches that deal with your pulse are going to be, again, that superficial temporal artery and then your facial artery. So pulse, facial, superficial temporal, terminal branches, superficial temporal, and maxillary. There is a little mnemonic down here that I learned when I took the class to help you memorize these 8 branches. SAVE for superior thyroid, A, ascending pharyngeal artery, lady, lingual, falling facial, out occipital, plain posterior, S, superficial temporal, and M, maxillary. So save a lady falling out of a plane Superman. Hopefully that kind of helps you out there. Again, where we normally see questions are dealing with pulse and then those terminal branches. But anything's fair game. All right, so talking about our carotid sinus and carotid body here. This one, generally a test question. Carotid sinus is going to be a dilation of the internal carotid artery. So sinus, we're thinking internal carotid, and then carotid body, we're thinking of common carotid. Now, the carotid sinus, its function is to act as a baroreceptor or a blood pressure sensor. And then our carotid body is here to act as a chemoreceptor. So essentially, with your carotid body, when you have a decrease in oxygen or an increase in carbon dioxide, it will result in an increased rate in volume of ventilation. So if you don't have enough oxygen or you have too much CO2, your breathing rate will increase, just to try to balance out your oxygen and your CO2. But that's what I mean by chemoreceptor. Really, you're just trying to keep a balance between oxygen and carbon dioxide. For your carotid sinus, we're thinking about if we had an increase in blood pressure. Again, the sinus is a baroreceptor or blood pressure sensor. That increase in blood pressure can lead to a decrease in heart rate. Now onto the internal jugular vein. So internal jugular, it's never going to be visible topographically, meaning if you look at someone's neck, you cannot see their internal jugular vein. It is deep to the SCM, and this is unlike that external jugular. So make sure you don't get tripped up here. Internal, you cannot see topographically. It is typically the largest vein in your neck, and it will drain into the brachiocephalic vein. Its tributaries, we have not seen this section really get tested over too much, so I'm not going to hit on it. That doesn't mean you couldn't pull something from here, so just be aware. Now we get to the nerves of the neck. That's figure 14 on bright space. First, we're starting with the glossopharyngeal nerve, otherwise known as cranial nerve 9. It's going to emerge from your medulla oblongata and pass through the jugular foramen. Starts with our tympanic nerve as one of the branches here. It's going to be sensory to the tympanic cavity and secretomotor to the parotid gland. Main thing here, that tympanic nerve is going to sense the pain felt when someone is dealing with otitis media or an ear infection. You then have the branch of the carotid sinus. These guys straightforward, sensory to both carotid sinus and carotid body. Pharyngeal branch, sensory to that pharynx, and it will sense the pain associated with a sore throat or acute pharyngitis. It's also the afferent limb of the gag reflex. We have branch to the stylopharyngeus, so this is just straight up motor to this to that stylopharyngeus muscle. It is the only motor branch of the glossopharyngeal nerve. So when you're thinking of cranial nerve 9, really thinking about sensory, but again, number 4 here, branch to stylopharyngeus, is its only motor component. We then get to our tonsillar branch. This is going to be what senses pain and tonsillitis. Lingual branch, that's going to be your taste, and it's specific to the posterior 1/3 of the tongue. Lingual branch, glossopharyngeal nerve, posterior branch, the posterior 1/3 of the tongue. Now we're on to the vagus nerve. This guy, maybe a little refresher from CNS, but it is going to be your longest cranial nerve. Vagus means wanderer. It's also going to emerge from the medulla oblongata, like the glossopharyngeal nerve will, and then exit through the jugular foramen. So we have some branches down here of the vagus nerve. You're going to want to learn these guys. These two sections here about the glossopharyngeal and vagus nerve, as far as the branches go, tend to be hit quite a bit on your first exam. Meningeo branch, again, we're talking about the vagus nerve here. It's going to be the source of cervicogenic headache. That's an important one. Obviously, us being chiropractors, we are kind of one of the go-to people for patients who are experiencing headache or cervicogenic headache specifically. If a patient presented with cervicogenic headache, you should be thinking about meningeo branch here. It also supplies the dura mater, and it's sensory. Auricular branch, so auricular, we're thinking about ear. That's going to be external to the ear. So it will sense pain in otitis externa, also known as swimmer's ear. Pharyngeal branch, that is going to be the efferent limb of the gag reflex, meaning it is the motor portion. So it takes your pharyngeal branch of the glossopharyngeal nerve, so pharyngeal branch, glossopharyngeal, to sense, the need for a gag reflex, that afferent limb, and then it takes the pharyngeal branch of the vagus nerve to create the motor response of the gag reflex. It's also going to be the chief motor nerve to the muscles of the pharynx and soft palate. Now we have this right here. We got our pharyngeal plexus is motor to all of the muscles of the pharynx except for the stylopharyngeus. So all except, the test questions are written for you right there. Pharyngeal plexus, motor to all muscles of the pharynx except for your stylopharyngeus. Because like we talked about before, your motor to your stylopharyngeus is a branch of the glossopharyngeal nerve. It's also for all muscles of the soft palate, except, again, we have another except for your tensor villi palatini. That guy is innervated by your trigeminal nerve. Anytime you see except or phrases like all of the following but, those are, in my opinion, test questions written directly in your text. We've seen them come up quite a bit. Every once in a while he'll switch it up, and he's got various versions of his exams, obviously, and writes new ones all the time. So this is just what we've seen a lot in the past. Superior laryngeal nerve. Again, we're talking about branches of the vagus. Got to know these guys here, internal versus external. So our internal laryngeal nerve, main thing here is it's going to be sensory to the mucous membrane of the larynx, superior, that's big, superior to your true vocal folds. External laryngeal nerve is motor to your cricothyroid and to your inferior constrictor muscles. Lastly, we're talking about the recurrent laryngeal. Sensory to the mucous membrane of the larynx below the true vocal folds and to the trachea. So make sure you know recurrent laryngeal, sensory below those true vocal folds. Internal laryngeal is going to be sensory superior to the true vocal folds. That's a common place where people get tricked up here. So make sure you hit this section here, kind of just be thorough with this section here. Make sure you understand the different branches of our laryngeal nerves here. Again, recurrent laryngeal is motor to all muscles of the larynx except the cricothyroid. I think we talked about that in our last one. So, clinical consequences of damage. We can have unilateral damage, and that will cause hoarseness or just partial aphonia, seen as a fill-in in the past. Or it can create bilateral damage, and that's where you would get complete aphonia, possible fill-in, and that's just when you're mute. You can't talk, and it can result in possible suffocation as well. There are quite a few causes here. So trauma from that thyroid surgery, like we mentioned before, a goiter or thyroid tumor could affect it. Lung tumor can affect it, as the apex is very close to that thyroid kind of area. And then we have your aortic aneurysm. That would be on the left side of the body only. Now we're on to our accessory nerve, or otherwise known as cranial nerve 11. We have a cranial part and a spinal part. So that cranial part is going to come from that medulla oblongata, but the spinal part is coming out from the sides of the spinal cord. They're both going to have the same exit though, jugular foramen. So the cranial part will join the vagus, and it will supply the vagus with motor fibers. So you'll have your pharyngeal branch of the vagus, again like we talked about, supplying muscles of the pharynx and soft palate. Recurrent laryngeal nerve, motor to the larynx. And then the spinal part of our accessory nerve, which should be a review from CNS, is going to be motor to your SCM, sternocleidomastoid, and then your trapezius muscle. Now we're on to our hypoglossal nerve, cranial nerve 12, motor nerve to the tongue. It originates from the medulla oblongata, and then unlike all of the nerves we talked about before, your hypoglossal nerve is going to exit the skull via your hypoglossal canal. So its exit is named after the nerve itself, and it has been seen as a test question in the past. We got quite a few branches of the hypoglossal nerve. Meningeal branch supplying the dura mater. Then we get into our superior root of our ansa cervicalis. So that's going to be mainly your C1 fibers. It will eventually unite with the inferior root, which is carrying C2 and C3, to form just the ansa cervicalis as a whole. That will be motor to your infrahyoid muscles. So like we talked about, our sternohyoid, sternothyroid, omohyoid. Now we have nerves to the thyroid, thyrohyoid and geniohyoid. It's going to be mainly C1 fibers, and the nerve is named for exactly what it does, motor innervation to the thyrohyoid and geniohyoid. Lingual branches, motor to your extrinsic and intrinsic muscles of the tongue, both of these guys. Lingual branches controlling both the extrinsic and intrinsic. Been seen as a true or false before. We get into our cervical part of the sympathetic trunk. Preganglionic sympathetic fibers, which supply structures of the head and neck. So this cervical part of the sympathetic trunk is coming from T1 to T3, and then it'll travel up the trunk to your cervical ganglia where it synapses. So your sympathetic ganglia include your superior cervical ganglion. That is going to be the largest ganglion. It supplies sympathetic innervation to your entire head. It's at levels C1 to C3. Then we have your middle cervical ganglion. It's going to be at C6. We have vertebral ganglion is going to be at C7. And then we have a little fact here. Vertebral ganglion is variable and is often fused with either the middle or inferior cervical ganglion. And then we have our cervicothoracic or stellate. Stellate, we're thinking star-shaped ganglion, found from C7 to T1. It's formed via the fusion of the inferior cervical ganglion to the first thoracic ganglion. With this section here, when I took the exam, the questions were very heavily weighted towards the vertebral levels of all these guys. So when you're going through, know that superior cervical C1 to C3, middle we have C6, vertebral we have C7, cervicothoracic we have C7 to T1. Then we get to the ansa subclavia. It's just going to be a nerve bundle, loops anterior to the subclavian artery, connecting the vertebral ganglion, so your vertebral ganglion, to your cervicothoracic ganglion. All right. Now we're getting into mandible and associated structures. We have a lot of osteology here. This part tends to be more of lab type questions for your lab practicals, but we'll go through it still. So mandible, it's largest and sturdiest facial bone. Largest, sturdiest. We have your body, alveolar process, ramus, angle. And then the two I like to point out are your condylar process and your coronoid process. Condylar is going to be what articulates with the temporal bone, and it forms your temporomandibular joint, otherwise known as TMJ. We have your coronoid process, and that's where muscles that help you chew, mastication, chew food, will attach. So both of those kind of stand out in comparison to the other parts of the mandible. It should be noted that there is an articular disc between the condylar process and temporal bone. So there is a small disc in your temporomandibular joint. I'm sure we've all heard of TMJ syndrome, which can be just a misalignment of the joint and a major cause of headaches. So look out for this guy. This is something that us as chiropractors can treat. Some other little tidbits about specific parts of the mandible. You have your superior mental and inferior mental spine. Superior goes with the genioglossus muscle, and then inferior goes with the geniohyoid. Again, we don't tend to see questions over the osteology on the exam, but he can always switch it up and throw them on there. I would worry more about them for the lab. Alright, so now, let's see here. These guys, they're pretty self-explanatory, but we'll run through them quick. So, you have our the sublingual fossa and submandibular fossa. Sublingual, it's the location of your sublingual gland, and then submandibular, location of the submandibular gland, pretty straightforward. It's important to note, though, that your sublingual is the third largest salivary gland. Your submandibular is the second largest salivary gland, and then like we talked about last time, the largest is going to be the parotid. Every once in a while, there'll be a test question over which is the largest, which is third, which is second, that type of thing. Now, we're on to some suprahyoid muscles and muscles of the tongue. Anytime you see a muscle section, it can totally be matching. Can't remember if I mentioned that last time or not, but typically it would be matching over function or innervation. So first we have our digastric muscle. It's going to elevate the hyoid bone during swallowing and then depress the mandible when the hyoid is fixed. Innervation, we have some stuff from the facial nerve and then from our trigeminal nerve to mylohyoid. Now we have mylohyoid, straight up, innervated by the unnerved mylohyoid, a branch of the cranial nerve 5. It functions to elevate the hyoid bone and then the floor of the mouth. Geniohyoid, C1 fibers from the hypoglossal, elevates the hyoid bone and tongue. Genioglossus, this is what these last two are what I was tested over. We have genioglossus is innervated by the hypoglossal nerve, as is the hypoglossal muscle or hypoglossus muscle. You want to pay attention to the functions here because they both work with the tongue. Your genioglossus is going to draw the tongue forward and it can protrude the tip of the tongue. Your hypoglossus muscle is going to draw the tongue downward. So genioglossus, forward, protrusion, hypoglossus, downward. And then this little note tends to show up quite a bit. Small portion of the hyoglossus muscle may take origin from the lesser horn of the hyoid in its muscle slip that's called chondroglossus. This is one that we almost always see as a fill-in. And it will also have the same innervation as the hypoglossus muscle, which is your hypoglossal nerve. Now we're on to the styloglossus. Again, we're talking about the tongue. This guy will draw the tongue up and back. So, in other words, it can retract the tongue back into the mouth. Also innervated by the hypoglossal nerve. Stylohyoid muscle. This one is pierced by the intermediate tendon of the digastric muscle. Usually this will be a quiz question for you guys, but again, I'm not sure if he's doing those, so it could potentially be more of a test question. Your stylohyoid is a bit of the odd man out here because it is innervated solely by the facial nerve. Everything else we've talked about has been hypoglossal in some way, or mylohyoid, a little bit from the facial up here as well. But this guy, stylohyoid, only facial nerve. It's going to elevate that hyoid bone and tongue. Now we're talking about the submandibular gland. Wraps around the posterior border of the mylohyoid muscle. You have a superficial part, which is the larger part, and it will be within the submandibular triangle. And since we're talking about the submandibular gland, it's going to be within that submandibular fossa. Then you have a deep part of the submandibular gland, and it is small. Superficial, large, deep, small. Small part will be superior to your mylohyoid muscle. Another number you might want to commit to memory. Submandibular duct is 5 centimeters long. It will open into the oral cavity on the sublingual caruncle. And that is located lateral. Located lateral to the frenulum of the tongue. So again, submandibular duct, 5 centimeters long, opens into the oral cavity on the sublingual caruncle, and located lateral to the frenulum of the tongue. Sublingual gland is the smallest, like I mentioned before, of the three major salivary glands. It lies superior to the mylohyoid in the sublingual fossa, and it will empty into the floor of the mouth via 12 short ducts. And then we have a little section here, just nerves associated with the mandible include lingual, glossopharyngeal, and hypoglossal. Lingual nerve will cross under the submandibular duct. That's something that you might use as a landmark when you're in lab. And it crosses under that duct on its way to the tongue. Sometimes we see it as a quiz question or a test question. Now we're on to our lymph nodes. So these ones are straightforward. Submandibular lymph nodes are in that submandibular triangle, submental lymph nodes in the submental triangle. Start of a new section here. We have our nasal cavity and paranasal sinuses. Got to know the functions of the nasal cavity. They're going to provide an airway. They're going to help you smell. They're going to warm and moisten inspired air. And they're going to cleanse inspired air. So that's a big deal because us being in Iowa, it gets super cold outside. You wouldn't want sub-freezing air entering your lungs without it being warmed up. We have a shot here of just kind of what our nasal septum, pharynx, conae, all that stuff looks like. Another one of just the nose. This type of stuff here, if you are at all tested over it, you'll see it on your lab practicals. We have the boundaries of the nasal cavity. So we have our roof, floor, medial wall, and then our lateral wall. So you got to know these guys. It's going to be a lot, but there will be some kind of test question over this. So the roof is going to be formed by nasal bone, frontal bone, cribriform plate of the ethmoid, and then the body of the sphenoid. Floor, palatine process of the maxilla, horizontal plate of the palatine bone, and when those two are combined, it's also called the hard palate. So the floor, hard palate. We have our medial wall, otherwise known as your nasal septum. So that's going to be formed by cartilage, and then the perpendicular plate of your ethmoid, and then your vomer. And then we're on to a little clinical note here about deviated septums. That's just when your nasal septum does not lie in the median plane. They can touch the lateral walls if they're severely deviated, and they can cause breathing difficulties. Causes can be congenital, birth injury, or some kind of trauma. And this here is an actual CT of my nose. So you can see right here how my nasal septum is definitely was deviated. I don't know how it happened. I don't remember having any severe trauma or anything. It could be congenital. I played a lot of baseball and soccer growing up, so I'm sure at some point I've been hit in the face multiple times, but nothing that I thought created any severe damage. But as I got older, I started having a lot of hard times breathing. You can kind of see in this section here, my the left side of my nasal cavity is almost completely blocked off via like this weird scar tissue stuff. So I'm a prime example of how a deviated septum can cause a lot of breathing difficulties. You just feel like you have a stuffed nose all the time. It's actually pretty miserable. I had the surgery to fix it. It helped a lot, but the surgery was pretty intense as well. So that's a story for another time. But we'll finish up here with the walls. Lateral wall. This is the one where our test question mainly came from. The lateral wall has the most to it. So Lateral wall is formed by our nasal bone, frontal process of the maxilla, lacrimal bone, ethmoid bone, inferior nasal concha, perpendicular plate of the palatine, and medial pterygoid plate of the sphenoid. So I know this is a lot to take in, boundaries of the nasal cavity. He can ask you about any of these: roof, floor, medial wall, or lateral wall. I would do your best. You know, medial wall, if I were to attack this, I would know this guy because you just need to know less. Septal cartilage, perpendicular plate of your ethmoid, and then your vomer. Boom, you got your medial wall done. Your floor, again, pretty easy to know. It's just the palatine process of your maxilla, horizontal plate of the palatine bone, forming the hard plate. And then the main thing is being able to differentiate between the roof and then that lateral wall. These guys have the most to them. So just be aware, this is typically a section that shows up on the exam. Now we're on to the lateral wall, specifically structures of the lateral wall. We have projections on our lateral walls called conae, or concha. I'm not really sure how to pronounce those guys. They are some of the thinnest bones in our body. We have a superior, middle, and inferior nasal concha. It's important to know what they're of. So superior and middle are both from that ethmoid bone. And then we have an odd man out with our inferior, which is just a completely separate bone. We have our picture here: superior meatus, middle meatus, inferior meatus. And then we have our superior nasal concha, middle concha, inferior concha. And then this guy, this is a pretty common test question. Again, the word variation. Frequently, we have a highest nasal concha, otherwise known as your fourth nasal concha. It is present above the superior nasal concha, so it would be kind of up here where I have this extra red one drawn. And it is also part of the ethmoid. So, if you were a person that had a fourth nasal concha, 3 of your nasal concha, your highest, superior, and middle would be from your ethmoid bone, and your inferior would still be its own separate bone. So we've seen that kind of pop up as a true or false type of question in the past. We'll end here. So we have our functions of the nasal concha: increased surface area. So that's important because it helps warm air, moisten air, clean air. Then it can increase turbulence. When you increase turbulence, it helps with our sense of smell, and it also helps, just like surface area does, with warming air, moistening air, and cleaning the air. All right, guys, I'll stop here. We did close to maybe 50 minutes. Got you 15 pages further. I hope that these tutorials are helping. It's still pretty strange just me talking to my iPad. It's usually a lot better to gauge where you guys are at with the material and how you feel about it when we're in person. So if these are helpful, that's great. If they're not and you have a suggestion that I can just do differently with past to help you learn better, please feel free to reach out. Again, my email is jacob.parks@palmer.edu. And that's all I got for you guys for this one. This is our second past session, March 26th. Second week of quarantine. I hope you guys are all doing well out there. All right. Thanks, guys.